Thank you so much for this kind introduction and for hosting me. And good afternoon to all of you, or on whatever time zone you virtually are joining from. It's really my pleasure to talk about the updates on the conundrum of mild HIE. I'm going to talk about how I got involved in this subject matter about 2 decades ago, from observations, clinical serendipity to new trial designs. I have no conflicts to disclose. My work is supported by NINDS. And what I thought I would do with the 45-minute allocated is talk first about the historical origins of this conundrum, review the evidence for cooling these infants versus normothermia, review some biomarkers for risk stratification, present some new data on surveys and parents' opinions, and try to come up at the end, not to leave you all hanging with nothing, with some proposed guidelines and updates on trial strategies. We all know that neonatal asphyxia is a challenging condition, and that the cascade of events that results is ongoing even after we successfully resuscitate these infants. And we really have limited therapeutic window of a couple of hours before the secondary energy failure to be able to mitigate and improve outcome with initiation of therapeutic hypothermia. The problem is that the resulting encephalopathy is dynamic and is being beautifully summarized by Dr. Sarnat and Sarnat in the 70s, describing an evolution in the first week of life based on serial examinations and EEG testing. And in reality, it has to do with the timing of the insult itself. Not all the infants are going to be presenting right at birth with the exact same presentation. Some of them are going to have prenatal, perinatal, acute on chronic, or even a postnatal insult. And that will dictate the presentation immediately in the first few hours after birth. The trials had to reckon with the limited hours to recognize those infants, and they had to adapt to a modified Sarnat score with 3 out of 6 categories empirically selected in the simplified scores that has these 6 categories, with the understanding that if we find hypothermia to work, we're going to have to address subsequently the infants that are below the tip of the iceberg. And this is how I got involved. I was finishing my fellowship at the time of those early trials, and we were part of the NICHE trial. I was part of recruiting and enrolling these infants and examining. And one of my first projects was looking at the predictive value of this early examination and how it correlated with the persistence of the encephalopathy in the first week of life. And the first observation was that infants do not line up into simple categories as normal, mild, moderate, or severe. And even if they did, the early definition in the modified Sarnat shows some overlap. And even if we were to look at the most specific differences, like between the level of consciousness, between mild and moderate, I found out in this early paper that was published about 20 years ago that a subgroup was difficult to classify. They had oscillating features between hyperalertness and lethargy, and a quarter of those progressed to have persistent encephalopathy in the first week of life. So really, this first paper casted doubts on the reliability of the early examination and its predictive values, and kind of those serendipitous observations led me into pursuing this subject matter with biomarkers and with the subsequent work that followed. Immediately upon implementation of hypothermia into clinical care in 2005, I had become a faculty at that time, and Tara Dupont was one of my first fellows. And her first task was to look into the infants that did not meet the cooling criteria that was from the NICHE trials. And she did extensive chart reviews comparing the infants who had a normal exam, but evidence of fetal acidosis and acute perinatal event, to those that had some abnormalities in the early examination, but did not meet the established cooling trial criteria. And what we found was that 20% of those infants had abnormal short-term outcome. We didn't have a protocol. We were not even doing MRI on all of those babies. We're talking about 15 years ago. And there was a progression to having seizures, MRI abnormalities. Even one infant had severe encephalopathy and had to be redirected care in those infants. At the same couple of years after, the McGill group with Pia Wintermark and her colleagues were having evaluations of the infants that were referred to their program for cooling but did not meet the cooling trial criteria. And they also showed that half of these infants were having MRI abnormalities. Of interest, we subsequently looked at multiple ways to score the abnormalities in infant with mild HIE. And Michelle Machi was my first neonatal neurology fellow. And she worked together with Lauren Weekey, Linda DeVries, myself, and we looked at multiple scorings and what we found is for infants with mild HIE, the highest number of infants, 50%, were found to have abnormalities if you use the detailed scores like the Weekey scorings, looking at white matter injury, bleeding, and other milder insult that can be encountered with a mild injury. More concerning is that the older studies were starting to report follow-up into school age, and we're reporting attention, memory, language skills, short-term and verbal working memory deficits where the longer you followed the infants, the more these became obvious and available, really highlighting the need for long-term, at least school age monitoring in these infants with a milder insult. And registries in the last 10 years have been documenting a therapeutic creep for mild HIE. And it's not one specific country or registry, the Vermont data, the Toby data registry, 43% of those infants were not meeting the study criteria. The problem with the registry, as by nature, when you have a database, you do not have a definition in the first 6 hours, and you don't have outcomes past the hospital stay. The CHND would be the largest of such database and had important information using the mild definition in the first week of life, according to the SARNAT score. 76% of those infants were cooled. And again, no long-term outcome provided, but confirming MRI abnormalities in about half of this cohort and EEG discontinuity in about 60%, few of them progressing into clinical seizures. The underlying reasons behind this therapeutic creep was beautifully described in the survey from the UK published a few years ago, showing that 75% of the providers that reported cooling said that they would do so because they were afraid that the HIE would progress, missing the critical window of cooling, and that it was so difficult in the first 6 hours to determine who has what kind of insult. And in fact, I dedicated a whole issue session in early human development in 2018, where we and multiple colleagues reported on short and long-term outcomes, biomarkers, and proposed therapies. I just want to hit the highlights to be able to focus on the more recent data. But if we look at the translational work done by Dr. Gunn and the group with UCSF, we find that with the milder, shorter insults, if anything, the animals were more beautifully responsive to hypothermia compared to a more severe injury. On the other hand, incidentally, cooling the normal brain, as was reported by the group from Johns Hopkins, you could see apoptotic bodies because when a normal brain is exposed to hypothermia. Moreover, the safety for cooling this particular group of infants with mild HIE has never been particularly studied. The cost benefit, the duration of hospital stay, separation from mother, all this remains to be seen for this particular patient population. If we look at the clinical evidence from trials, none of them were focused or targeting mild HIE. Those that were kept based on an intent to treat analysis, overall combining all of the prior trials would be less than 100 total and were not powered, but showed trend toward benefits. If we look at the largest study by Dr. Jacobs in 2011, it still had about 20 patients in each arm and also was not powered, but showed a promising trends for a reduction of disability from 33% to 25% in infants with mild asphyxia. The remaining of the literature really is prospective observation that I try to summarize here. Small numbers of infants with mild HIE, no definition of what constitutes mild HIE in the first day of life, and a whole range of outcomes ranging from 6 months to school age outcomes. Important findings, if we put them all together, about 25% of those infants would be at risk for having 1 standard deviation outcomes below the norm. But again, no clear granularity about how to define mild insult in the first 6 hours after birth. It is this that led me to initiate the PRIME study with 6 other sites, looking at validating a definition early on and correlating it with short and long-term outcome and with the utilization of the SARNAT scores. And the findings were published, but again, just hitting on the highlights, because there was no consensus for an early definition, we wanted to be as inclusive as possible. So all the infants who had an acute perinatal event and fetal acidosis and did not have a normal exam, but had any abnormalities that did not meet the cooling trials criteria were included in this analysis. We were able to have predefined outcomes, serial examinations, standardization of the examinations and of the central reading of the outcomes, including the 2-year outcomes. And what we found was that 52% of those infants had abnormalities before discharge, whether it was an abnormal examination at discharge or discontinuity on EEG or MRI abnormalities. And then when we looked at the NICHD criteria, similar to the cooling trials, we found that disability was documented in 16%. There were no deaths, but if we looked at Bailey scores under 85, we had about 40% of those infants, and the most common deficits were cognitive and language, very few motor, very few cases with autism were reported. If we look at the granularity of those scores, you see here each of the cognitive, language, and motor Bailey scores at 18 to 24 months. And what we found was that for the cognitive score, there were about 5 points lower than the norms. For the language, about 10 points lower. And that really was correlated with the subsequent cohorts from the European colleagues that had 4 cohorts combined, also using a similar definition in the first day of life, also showing that the infants with mild HIE had scores that were 5 to 7 points lower than their compared controls. So really, this contemporary data that I've showed you in the, try to summarize it at least, because there are many publications that have been coming up on that, that are too numerous to even fully summarize. The special editions are there for that. But really, that contemporary data using the definition in the first 6 hours of life from PRIME showed us that indeed encephalopathy is a spectrum, and that the fine gradation between mild and moderate are very difficult to sort out. It's very easy to know who's got a severe insult, easy to know who's got a normal exam, but what happens in between is very difficult to differentiate early on. And now we know with clarity that lumping together infants with moderate and severe versus infants with normal and mild, that was, as was done in the early trials, might have been appropriate then, but now it is a whole different matter. And we need to decide where to draw the line regarding the risk benefit and the evidence for providing cooling for those infants with a lesser encephalopathy. And if we look at biomarkers and scoring, we know that the Thompson score has been validated with the early trials, but really it was not meant for mild asphyxia or for the first day of life, because it included things like feeding and presence of seizure. It was meant for predicting outcomes during therapy. But if we look at the same concept with the total SARNet score, we find that we can quantify the number of categories being abnormal from 1 to 6, and the severity of each from 0 having a normal exam to 3 having a severe exam. And when we did that for the PRIME study as a secondary analysis, to give you an example, the lowest possible score would be 1 for 1 abnormality. The highest possible score for those that do not meet the cooling trial criteria would be to have 2 severe abnormalities, hypothetically speaking. We didn't have a real patient like that. And the remaining be mild abnormalities. So if you add up the score, you would have a 10. And to give you a reference range, the validated scores for the cooled infants would have a score ranging from 6 to 18, since those infants would have to have at least 3 categories as moderate to receive hypothermia therapy. What we did in the secondary analysis study for the PRIME patients is we looked at the SARNet score, and we were able to confirm that infants that had disability at 2 years all had a score above 4. Of course, some of the infants with a score above 4 had a normal outcome, and this is reflected in the receiver operator curve on the right side of the screen. Similarly, the MARBLE study further validated after our publication the total SARNet score for the full range in a cohort of both mild, moderate, and severe asphyxia that received hypothermia therapy. So unlike our PRIME patients who were not treated, those infants were treated. But similar findings, a score of under 4, all of those infants did not have disability, as seen in green, and then increasing disability was seen with increasing scores in infants with moderate and severe encephalopathy. And really, this emphasizes that if you're a site that practices hypothermia as a standard of care for those infants, at least one way to do it systematically would be to use a scoring above 4, so that you would not have to rely on variability from physician to physician. But also in this particular setup, I want to emphasize the importance of neuromonitoring. And we have published part of the seminars in fetal and neonatal medicine edition dedicated to neonatal encephalopathy on behalf of the Newborn Brain Society guidelines and publications, the importance of bedside monitoring for neonatal encephalopathy. But if you note in that review, what I summarized is that most of those biomarkers are excellent for predicting a severe encephalopathy with a reperfusion injury. I still think for a mild insult, it's important to perform an EEG or an amplitude EEG. And the reason is, if you see seizures or if you see these suppressed tracings, then this infant does not have a mild insult and has to be reclassified as moderate. And also important, if that infant had a seizure, obviously, that infant would have to receive hypothermia. I also at Parkland, I can tell you, I use an armamentarium of biomarkers to try to help time the insult and tie the picture together to give a prognostic information for the family. But I noticed that, again, like NEARS is helpful for a more severe insult indicating a reperfusion, but really for those with a milder insult, we need non-invasive, dynamic physiological biomarkers. And this was the subject of my next set of investigations. And the reason being, you have neuronal activity, blood pressure, multiple signals in the human body that are oscillating at different frequencies. And if we want to use the mathematical assumptions, like the Fourier analysis, to be able to make analysis, we have to make assumptions about a stable, non-changing linear signal. The problem is anybody who's taking care of an infant with asphyxia knows that there is nothing stable, linear, or non-changing about these infants. And so I had to look for alternative methodologies, and I teamed up with bioengineers, and we looked into the wavelet signals, that the same as what we use to predict, hurricanes and tornadoes that are equally non-predictable. You have the same thing with an asphyxial insult. You need to look at a long duration of time over the x-axis, and you need to look at multiple frequencies on the y-axis for multiple signals involved. Unlike the prior assumptions, this research tool I found out was very helpful. It's used on the natural health, but it's also very adapted to our medical field, because again, you have exact granularity for a long duration as much as you need it, and for a multitude of oscillations and signals. And more so, the wavelet signal tells you a visual about significance of how the signals are correlated together. The little arrows inside tells you about the phases and the coherence, because not everything needs to be a mirror image. You can have very complex time lags or phases that can be involved. And what we did in the first paper, we looked at cerebral autoregulation, looking at the correlation of two signals, blood pressure and cerebral blood flow. And we found that when you included all the signals from the wavelet, you improved the accuracy to 88.9% for predictions of the 2-year outcomes in moderate and severe asphyxia infants that received hypothermia. And then I looked at neurovascular coupling non-invasively with this advanced methodology, but now we're looking at two signals, one involving cerebral functions with EEGs or amplitude EEGs, and one involving cerebral blood flow with NIRS or other proxies. And while individual patients, as this example, show a normal NIR and a normal EEG compressed tracings for those two cases, that visually you wouldn't be able to tell the difference. If we look at the advanced signal processing, one infant had a normal neurovascular coupling and one infant had impaired neurovascular coupling. When you look at the collective data in the first pilot, we were able to confirm that those that received cooling with moderate and severe HIE and had abnormal outcomes had neurovascular coupling of 10% or less compared to the infants with a normal outcome. We then went ahead and looked at the rigor of the Wavelet bundle with multiple methodologies, multiple tools, after we looked at the different ways of achieving pre-processing and the Wavelet as the optimal mathematical model to look at those signals. And in this first paper, it was a postdoc, and his PhD project he was tasked with looking at the rigor of the neurovascular coupling measurements using multiple amplitude EEG algorithms and devices at the bedside. We all know that we take care of babies in each hospital. Sometimes the same institution, 4 hospitals would have 4 different monitors with different algorithms, the commercial algorithms not being even disclosed. And a picture says it better than 100 words, not to belabor too much on the topic, but this is same subject, same recording, different algorithms for processing amplitude EEG have different filtering signals, and the EEG is seen directly, processed EEG is seen in blue. All those have variability. But if you look at the wavelet data, at the spectral analysis and the frequency on the y-axis, you find that for all these devices, the variability was on the high frequency range. Luckily for us, the NIRS physiological signals for blood flow and perfusion, they're happening at the low frequency range. So when you couple the two signals together, and when you want to do neurovascular coupling with the wavelet, you see here a whole range of outcomes, neonates, different presentations, high neurovascular coupling, low neurovascular coupling. And for each, for example, newborn 1, different methodology, same baby, same data set, the Wavelet gives us the same numerical and visual algorithm. And we confirmed that with a Bland-Altman analysis. So really showed that this is a good way to look at the data. We confirmed with a second cohort, and we did show that the infants with an abnormal MRI, this one was obtained on the first day of life. The prior work, the initial work, was moderate and severe asphyxia undergoing cooling for 72 hours. Now we validated this in the first day of life, showing that in the low frequency range, the groups with abnormal MRI had lower neurovascular coupling. Best part is whether you had originally been labeled as mild or moderate encephalopathy, as you see in this graph. This is not published yet. The neurovascular coupling was different in those who had an abnormal MRI and lower. And when you compare it to the total SARNAT score seen here, you see that a neurovascular coupling score of 10 or more predicted better the outcomes for those infants. And again, this data has not been published yet, but it's very promising for those infants. And I hope that I just gave you a little bit of a perspective on this work that is still in progress that I'm doing on quantitative and qualitative EEG to help guide the management of those infants with mild asphyxia in the first 6 hours of life. And again, this work is still in progress. I did promise to try to come up with where are we now and what do we do with the data that we have. And in the coming 15 minutes or so, we're going to review where we are and what we should be doing for those infants below the tip of the iceberg. In 2017 and in 2018, I remember presenting at the PAS on mild HIE. And then I remember before the Newborn Brain Society became a society, it was called the Neonatal Neurocritical Care. The first publication came in 2018, was published in Pediatric Research about the need of more evidence-based data for these infants that we collaboratively put in this review. And then in 2021, we performed another review regarding the unanswered questions in this group of infants that also was published in the Seminars of Fetal and Neonatal Medicine, Neonatal Encephalopathy Special Edition that I talked about earlier. And on behalf of the whole committee, we were summarizing the lack of systematic evidence regarding neurodevelopmental outcomes and risk-benefit. We know those babies are at risk, but we do not know the risk-benefit of the therapy nor their responses comparatively to infants that were not cooled. In the American Academy of Pediatrics in 2014, the recommendations were that therapeutic hypothermia would be used for those infants with moderate and severe neonatal encephalopathy, but may be beneficial for those with infants in mild neonatal encephalopathy. If we look at the population trends, this recent paper this year from the UK showed, if you look at about 400,000 infants admitted to the NICU in the UK, we find that about 61% of those that were cooled had moderate and severe asphyxia. The remaining did not meet cooling criteria. A lot of them had mild HIE, and the numbers have been significantly increasing in the last decade if we look at epochs. Similarly, the work recently published from the California group showed a doubling in the number of infants receiving therapeutic hypothermia between 2010 and 2018, with variations in the management of mild HIE and therapeutic drift to cooling more prevalent if we look into year-to-year analysis. Luckily, there was low mortality in this group of infants, but definitively significant resource utilization for those infants that receive hypothermia. If we look at the individual cooling of those infants on a one-to-one basis, the last survey that I did the past year with the Newborn Brain Society with 489 participants, I gave cases with acute perinatal event, irritability on exam, 2 categories using the prime definition being abnormal. And I polled the audience regarding who would cool and who would not. And the amplitude EEG was normal because some of the colleagues use this as one of their criteria. And on that case, it's about 50-50 regarding cooling or not. When I gave them another case immediately after with the same perinatal presentation, but now 2 categories being scored as moderate. So the trial said 3, now you have 2, what would you do? There was about 80% that would cool those infants and 20% said no. Similarly, a PAS poster presentation with Dr. Singla that I helped with was presented at the last PAS meeting, and I gave them the same cases. Now we're involving more middle-income countries and low-income countries, not just the US, the UK, and Canada. And what we found was similar responses. It doesn't matter where people are answering from. For the first case, about half and half. For the second case, about 70% would cool. So what do we do? And how do we manage? We keep recommending in our reviews and editorials that are too numerous to list and even summarize in a talk that something needs to be done. But yet, the data that I just showed you shows that the therapeutic creep, if anything, is more prevalent. And the variability in practice is definitively something that we struggle with on a day-to-day basis. If we look at the published reviews and editorials, we know that, and from the prime data, we know that to have power and to look at cognitive scores under 85 using the disability criteria from prior trials, you'd need about 500 to 600 infants for a randomized controlled trial. And yet, we know from the pilot data, this has been very hard to achieve. The COMET study published on the first 30 infants, but had to revert to a non-randomized design where infants were all cooled, but then were allocated randomization to different duration of cooling. The time study in California also was slowed down with recruitment because of COVID and the difficulty of recruiting mild HIE. The mild darbepoetin data with Tara Dupont that I told you about earlier also took twice as long to complete recruitment of the 20 infants. What this data overall showed us, though, was promising. If we look at the COMET study infants that were non-randomized, the infants that were cooled compared to the infants that were not cooled, those that were cooled are seen in blue, and you see that even though that we were not powered for language or motor scores, there were no significant differences. When we look at the MRI spectroscopy, they look to be very promising biomarkers with the infants who were receiving cooling having improved scores. Similarly, the darbepoetin data showed feasibility of giving Darby. The benefit here would be 24 hours rather than 6 hours. And of course, small numbers in each group and was not powered to show any benefits. But and it would be interesting to see what the HEAL study for the moderate and severe HIE shows, because then subsequently, if beneficial, that could be a promising alternative for infants with a milder encephalopathy. But at the current time, based on the available data, for me personally, I thought that involving families and parent advocates would be very important, because the truth is, it's controversial. We do not know. Even as physicians, we realize it's limited evidence, but we realize these infants are at risk. And what would the family and stakeholder think about that? So I first conducted, with the help of Hope for HIE, a survey for a focus group of parents for infants with HIE. And 87% said that they would not consent to a randomized trial. They would prefer either the standard of care for that hospital to be applied in a comparative design to get to the missing information that we need. They acknowledged that we needed more data, but the parents felt that it would be very hard to consent to a randomization. I then conducted a larger study with the help of both the CP Foundation, Hope for HIE, 400 participants. 75% were parents, and about a third of those were survivors with mild disability, because it's important to see how those people perceive the risk benefit and the importance of management during the NICU stay. And what I found, and again, this data is still not published, is that we had a good representation of various education and backgrounds. And similarly to the focus group, 26% only would agree to a random allocation of treatment. And the remaining overwhelming majority would prefer the treatment to be decided with guidelines of the regional hospital and comparative effectiveness designs. And that really led to the CoolPrime proposal that is right now pending funding, where we could stratify by site. If we cannot randomize, we just use the site practice and look at the longitudinal cohort with outcomes to be able to guide the ongoing management of these infants. And the review is going to be next month. I really hope that we can get started on this important study. But while we're waiting, I'll tell you what I do, and then we can open it up for discussion. Like I presented earlier, I like to collect as much data as I can within the hospital stay. I have been able to do an EPIC automated serial examination so that we could track those infants. And I provide the same order set for those infants as I do for those with moderate and severe asphyxia, including an EEG to make sure they don't have those suppressed tracings, including sending placenta for pathology, because one of my earlier studies that I didn't have time to present, infants who had velitis or inflammation had worse outcomes. So at least it can help us understand and prognosticate for those infants. And I like to perform an MRI if possible before discharge. We're not seeing lots of basal ganglia, luckily, but we're seeing those white matter injury that I described earlier. So I try to do all of this. And I try to do the dynamic biomarkers that hopefully I can present more on in the coming year or two. And more important, this issue is in press. I wrote a review for clinics of perinatology. I recommend importance of video EEG, amplitude EEG, serial examination, multiple classification of the etiology and trajectory of outcomes. And to leave you with a take-home message before we open this for the whole group, it was a lot to cover. I have been working on this topic of mild neonatal encephalopathy for about 20 years now. Started with a serendipitous observation, to biomarker studies, to the realization that the loss of equipoise in clinical practice is real. Some people like to say that this is not happening, but I think I've showed you enough data that shows that this is happening. We have a problem and we need to find solutions. Until we address the cost, the risk benefit, the safety, the comparative effectiveness, I would say avoid hyperthermia at all costs. Think of temperature as a drug. Use standardized protocols for your own protection. It's not good to have one physician cool, another one not. Do serial examinations. The minute you are concerned that they're meeting criteria, then cooling needs to be initiated. Perform follow-up as much as you can to keep track of those infants. And for me, as I embark into my next study from prime to CoolPrime with 15 academic sites, parental involvement is essential. And I hope I can update you and give you more good news on the next time I'm presented to talk. But I think I've made the case that it's time to shake the box a little bit and provide some new data, because right now we don't have data that we badly need. And on that note, I would like to thank you for participating today, and I'm eager to look at your feedback, questions, and answer to the best I can, what I can. This is our campus at UT Southwestern. These are our lovely new hospitals for any of you who have not visited. This is my Neuro-NICU team. It takes a whole team to implement those strategies and those changes and those studies that have been presenting for the past 15 to 20 years. And I would like to open it up for further discussions. Thank you so much.